welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
We have Madison Botkins, who is a P3 pharmacy student at University of Kentucky College of Pharmacy. Today, she will be presenting a journal club on acute adverse effects of FabAV and FabAV use for Rattlesnake Envenomations, a 4-year poison center study.
So for a background here, I'm just going to talk a little bit about some of the studies introduction. So for snake envenomations in the United States, we have approximately 8,000 bites that occur each year, and about 5 to 6 of those result in death of the patient. In 2022, there were 4,500 crotalid bites, but only 940 of those were classified as rattlesnake bites. So when we're specifically talking about relevant snake species in the U.S., of course, we're talking about the rattlesnake, which includes the eastern and the western diamondback, timber rattles, copperheads, cottonmouths or water moccasins, and of course, coral snakes. I have some pictures here on the right for you, just for your reference. In the top left, that's the eastern diamondback. On the top right is a copperhead. Bottom left is the timber rattle, and then the bottom right is the coral snake, which is native to Florida. And just as a fun fact, coral snakes are not a member of the crotalid subfamily. So regarding the 2 commercially available antivenoms that we'll be discussing in this study, they won't work for the snake. So just to get into more about what exactly the study is looking at, they are analyzing CroFab and ANIVIP and comparing the 2 of these in the frequency of their adverse effects. So just to give us some background about the differences between CroFab and ANIVIP. CroFab is the Crotalidae polyvalent immune fab. It comes from sheep. It was the older version of what's available on the market and was approved in 2001. And notably, when it was first approved in 2001, it got approval for all North American crotalids. So that includes copperheads, cottonmouths, and rattlesnakes. CroFab is a single fab fragment with 1 venom binding site and has a half-life of about 12 to 23 hours. In comparison, ANIVIP is Crotalid Immune Fab 2 equine, so it got approval much later in 2018 to come on market, and it is derived from horses. So specifically of note, ANIVIP, when it was first brought to market initially, it was approved only for North American rattlesnakes. So ANIVIP is the Fab 2 fragment with 2 venom binding sites, and it has a significantly longer half-life of about 5.5 days. So the purpose of the study that we're looking at today was, as I said before, to compare the frequency and the type of acute adverse events, or AEs, I'll just hereby call them AEs, between CroFab and ANIVIP. So just as some background for what we currently know of antivenoms, the reason they decided to conduct the study was because most of what we know about the AEs from antivenoms was from when the clinical trials were conducted. There's no advanced literature beyond that, really, comparing these 2 head-to-head. But just in general, based on what we have in post-marketing reports, we know that they can cause flushing, nausea, vomiting, wheezing, swelling, anaphylaxis, and sickness or delayed reaction. So to talk through the pictures I just have attached to the left side of the screen here, this just shows a brief depiction of what happens in the manufacturing process. So we start with the whole IgG antibody, and to make CroFab, they use papain, a specific enzyme, and then they get 1 fab fragment. And then to create ANIVIP, they use the pepsin enzyme, which results in this Fab2, and it has 2 venom binding sites, like we said before. Picture underneath that here, just a super brief manufacturing process. They decide that they want to create an endovenom against a specific snake. They'll extract that endovenom from that snake, inject it into an animal, whether that's a sheep or a horse. It's a horse in this case. Then they'll withdraw blood from that animal. It'll go under purification process. And then after all of that, you have the final antivenom that can be used for patients. So to get into their methods and their study design specifically, this was a multi-center retrospective chart review analysis, and the cases were collected by referral from providers, specifically patient cases that were reported to the California Poison Control Center. They collected the antivenom type, how many vials they gave the patient, and of course the documented adverse effects, but specifically the ones that occurred after antivenom administration. So one of the more important definitions that the study discusses is that they have a specific category for their clinical effects of envenomation. And they define these as one, being vital sign abnormalities like hypotension, tissue toxicity, so swelling, pain, bleeding, etc., hematologic toxicity, thrombocytopenia, abnormalities in PT, INR, etc., and then neurotoxicities, including fasciculation, myokymia, numbness, tingling, etc. The total duration of the study lasted 4 years, from October 2018 to August 2022. And notably, they decided to start in 2018 because that's when ANAVIP got approval. So another important thing that the study described was that they defined an AE as something or symptom that occurs after administration of an antivenom, and it has a histamine-related or allergy-type presentation. They have a subcategory as well, so they broke down these adverse effects as either being acute non-severe or severe AE. So their criteria for a severe AE is that multiple organ systems were affected, the patient experienced hemodynamic compromise or systolic blood pressure less than 90 in adults, or any value below the age normal range in children, if the patient experienced swelling in the airway, or if the patient had anaphylaxis or an anaphylactoid reaction. Any other adverse reaction that happened or was documented in the patient after antivenom administration that didn't meet the severe criteria was just classified as a non-severe adverse effect. Another important note in the study is that all adverse effects were recorded both individually and on a per patient basis to allow for multiple AEs to occur in the same patient. And just to make sure I cover all their bases here, an allergy type presentation, of course, that includes urticaria, rashes, itching, respiratory symptoms, hypotension, etc. Okay. So now we're moving on into their inclusion and exclusion criteria. Patients who sustained a rattlesnake bite that were ultimately treated at a healthcare facility were included, and there were no other direct statements within the study of what else they might consider for inclusion. But they did provide more information for exclusion. Patients who did not present to a treating healthcare facility were excluded, patients that were determined to not require antivenom at all, and then patients that received both CroFab and ANAVIP in the same visit. The statistical analysis that they conducted was a chi-square or a Fisher's exact test. So getting into a little bit of their results, their sample size in total was 481 individuals. 360 of these individuals received CroFab, or about 75% of their population. 121, or about 25%, received ANAVIP. And then just comparing some baseline demographics right here in this little comparison of CroFab and the ANAVIP group, the median age was roughly similar between the two groups, 47 in CroFab and ANAVIP was 46. Median number of vials in CroFab was 6 compared to 10 in the ANAVIP group. And importantly, this kind of mirrors the initial dosing recommendations for both of these drugs, so that's not surprising. As for the demographics of the patient, 72% were male in the CroFab group and 73% were male in the ANAVIP group, which is expected as well. They're not too different between groups. The table on the right here is just a collection of the different adverse effects that occurred, with FabAV being CroFab on the left there, and then ANAVIP being on the right. Most important takeaway from this little table here is that rash and urticaria was the most commonly reported adverse effect, and then CroFab just has numerically more adverse effects that are occurring. So going into the actual frequency of the adverse effects that occurred. So for CroFab, there was one patient in this group that actually had envenomation-associated anaphylaxis. So the patient actually had an allergic reaction to the snake venom itself. As for non-severe acute adverse effects, 18 occurred in 12 of their patients, so about 3.3%. And then 1.1% of patients had rash and urticaria, and 5 patients had a severe acute adverse effects, or 1.4%. In comparison, the ANAVIP group, only 2 non-severe acute adverse effects occurred in 2 patients, or 1.7%. Similarly, 1.7% of their patients experienced rash and urticaria, and then 0 severe adverse effects were reported. Now here at the bottom, I just have a quick statistical analysis here regarding their data. So the relative risk for their non-severe adverse effects came out to be 1.94. Interpreting that means that the patients exposed to the CroFab group, or the patients that were in the CroFab group, have a 1.94 times the risk of experiencing an acute non-severe adverse effect compared to patients that were exposed to ANAVIP instead. The relative risk for rash and urticaria, on the other hand, is 0.6. So this means that patients that had CroFab had a lower risk of rash and urticaria compared to patients that were exposed to Antivip, despite the fact that in the CroFab group, there were numerically more patients that had rash and urticaria. And then the risk of a severe adverse effect is 1.4% higher in patients that received CroFab compared to patients that had Antivip. So moving on to the discussion for this study, patients that received CroFab had more acute adverse effects compared to patients that received Antivip. There was a small but statistically significant difference in acute adverse effects that met the severe criteria for CroFab compared to Antivip. But overall, the rate of these adverse effects was low for both antivenoms. So the authors do have a section where they go into why CroFab may have a higher rate of acute adverse effects. And the first one that they provide is immunogenicity or differences in manufacturing. So I brought back this slide that we discussed earlier. This is the manufacturing process for the two antivenoms we have. So CroFab, when it gets cleaved by papain, it is cleaved into two Fab fragments and one whole FC fragment. This FC fragment is highly immunogenic and binds to effector immune cells as well as C1q receptors, and these can activate the complement cascade pathway. Normally, these FC fragments are filtered out during the manufacturing process, specifically for CroFab. However, it's not guaranteed to be 100% effective, so there may be residual FC fragments left behind. And because of its very high immunogenicity, that's what could be causing some of the higher rates of adverse effects that we see in patients. In comparison, Antivip is cleaved by pepsin, and pepsin metabolizes the FC fragment and leaves behind the Fab2 fragment and the PFC fragment. So it is less likely overall to bind the effector immune cells and that C1q protein due to the lack of an intact CH2 subunit, and that subunit is specifically required to bind to these cell types. The second difference they listed was with the cleaving enzyme. So again, that's listed here in this picture. There's papain for CroFab and pepsin for Antivip. Papain is found in raw papaya, and it actually has antigenic similarities with latex and dust mites. And one of the relative contraindications to using CroFab anyway is if patients have an allergy to papaya. The third one they list is protein content. So one vial of CroFab can contain up to 1,000 milligrams of protein versus one vial of Antivip. Antivip has no more than 120 milligrams. So the authors suggest that there may be a higher antigenic response just due to the differences in protein load, where CroFab's is so much more higher than Antivip's. But they do state that there's no evidence yet that supports this connection between how much protein is in an antivenom and the likelihood that a patient experiences a hypersensitivity response to this. So getting into their strengths and limitations here, some of the strengths I noted was that it was a comparative analysis of the two commercially available antivenoms. So it is filling that gap of information that we lacked where there was no literature describing acute adverse effects beyond the clinical trials. It was a standardized review, so each patient case was reviewed by board-certified medical toxicologists or fellows, and there was at least 2 on each patient case. And overall, the study had a 4-year duration, which I believe was in its favor. In terms of its limitations, of course, it's a retrospective chart analysis, so those come with a whole host. But to be more specific, they had an inability to ensure standardized adverse effect documentation. So because they're relying on patient cases that were reported to the control center, these could have come from a variety of different institutions, all of which can have different processes in the ways that they document things for patients. They also did not collect timing of any adverse event relative to the antivenom administration. So it is quite hard for them to definitively define what time period in which that a patient experiences a symptom and if it's related to the antivenom. So that can be just a little bit difficult. They also excluded patients that received both types of antivenoms. So we're excluding a whole group of patients that may have been switched to the different one because they had like an adverse effect like anaphylaxis or a severe allergic response. They're also limited to patients that were reported to the California Poison Control Center, so we're not getting any geographic or demographic data beyond that region. And of course, their population size was quite small. To get into my concluding thoughts, I believe that the findings in the study would likely not impact our current standard of care for snake envenomations. As was stated in my introduction, I'm from the University of Kentucky, so I'm pulling directly from our protocol. At UK, we have CroFab designated as our treatment of choice for patients that have either moderate to severe snake bites, which is calculated by the snake bite severity score. If they are moderate, they will get 4 vials, and if they're severe, they'll get 6, and then redosed as needed. So importantly, when CroFab was first introduced to the market, it could be used to treat crotolid envenomation. So that included copperheads and cottonmouths, which is important when you're from an area like Kentucky, where these snakes are far more common than rattlesnakes. However, it's important to note that ANIVIP received this approval 3 years later after its market introduction. In 2021, it is also approved for copperheads and cottonmouths. And next is just a brief cost analysis. So CroFab is roughly $2,000 more expensive than ANIVIP per vial, but it requires fewer vials overall for the initial treatment. However, of course, this will depend on if the patient needs to be redosed. But UK also conducted a cost-effective analysis internally, and they determined that there was no significant difference in cost savings if they used ANIVIP versus CroFab. And since ANIVIP also gained that approval for some crotolid envenomations, the manufacturers of CroFab have actually reduced their cost as a response. And then for my second point here, for severe adverse effects, we did see that CroFab had slightly more of these. Would that be important when we're considering which one to choose for patients or which one to put in our formularies? I believe still you could go with either option, because if a patient experiences any kind of adverse effect, whether that's not severe or severe, if they're presenting to the ED or a clinic or some kind of hospital setting, we have medications that are readily available to treat these conditions. So we will have epinephrine for our severe anaphylaxis reactions. And then from this picture at the bottom is pulled directly from UK's protocol. For non-severe reactions, we could also think of giving the patient antihistamines or albuterol if needed. And then it also points out that pre-treatment is often not necessary if that's something we might also consider. It is an option, but not really necessary. And that is everything I had. So here are my references.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.